Hi, welcome everybody. Such a great group today. I'm Sharon Anderson, president of Leiomyosarcoma Support and Direct Research, or for short, LMSDR. We are really thrilled today that you've joined us for this webinar about Natera and their test called Signatera. Sorry, I'm tongue-tied with it today. And that's a test that detects whether or not your cancer cells are circulating in your blood. And if the cancer cells are present, they can actually count them. And if the number goes up or down over time, they can let you know while you're in treatment. So we're so grateful to have two representatives from Natera today, and that's Elizabeth Ganjoo. She's a regional director, and Samantha Scantlen. I'm not sure how to say your name. How do I say your name, Samantha?
Scantlen.
Scantlen, okay. Who's a clinical oncology specialist. And then, of course, our wonderful Dr. Kristen Ganjoo, who is a sarcoma specialist at Stanford. She's been using this test with some of her patients. Some of them might be here today. And you can let us know from your perspective how it is using this test. I want you to feel free to put your comments and questions in the chat box, and we'll have time to answer them after the presentations. So let's start with Liz and Samantha, who will tell us more about the test.
Okay, well, I'm going to share my screen here. One moment.
Looks like it's working so far.
There we go.
Okay.
Yeah, so I'm Sam. I am the local San Jose rep for Natera's oncology offerings. I work with Dr. Ganjoo and all the Stanford doctors on any testing they would like ordered. We just want to take a few minutes to give you a little bit of background information on Signatera. Some of you may have heard of it. It might be completely new to some of you. Signatera is a minimum residual disease test. It's really meant to answer three different questions. After surgery, is your cancer completely gone? During treatment, are you responding to it? And in a survivorship setting, has the cancer returned? So we're hoping that Signatera can help you and your doctor answer these questions. There's less ambiguity about your personal situation, and get you the best treatment possible if that's the path that you need to head down towards. So Natera has been around since 2004. We specialize in what's called cell-free DNA testing. That means little tiny pieces of DNA that break off and are floating around in your bloodstream. We first use this in reproductive health. We've also used this in organ transplants. We're looking for rejections before they actually happen. And right now we're using it in oncology. So the specific type of cell-free DNA in oncology is called circulating tumor DNA. So we are looking for little tiny tumor cells floating around in your blood. Our test is so sensitive, we can find one cancer cell within 2 tubes of blood. So here's some applications of Signatera. Many of you have probably had some type of cancer therapy selection done already. This would be your Foundation 1 test, Caris testing, Tempest testing. And that type of testing is looking specifically for cancer therapy selections. What targeted therapies will your specific tumor respond to? We actually have a test in this category as well called Altera that you can get ordered with or without Signatera too. But our more novel testing is our Signatera testing right here. So like I said, it's minimum or molecular residual disease testing. You can use it for surveillance, for early recurrence monitoring, and for treatment response. And over here, asymptomatic cancer screenings. These are cancer screenings that are extremely new. There's a company called Grail out there doing it. And this would be for patients who have no cancer, no known cancer, and they're screening for it. So how do we do this testing? First of all, we do request one of your biopsies or resection pathology tissues from pathology. So your doctor will send us a pathology report. We will request the tissue ourselves, have it sent directly to Natera. And then what we do is we sequence the tumor tissue. We use what's called whole exome sequencing. So we are sequencing 20,000 genes in your specific tumor. And we are trying to create a fingerprint, an individual fingerprint for your specific tumor. And after that, we use that to create a personalized assay. So we're creating an assay for every single patient, like a brand new one just for you. The initial process to create this assay is about 3 weeks to get that whole process, because it does take a little bit to get the pathology lab to send us the tissue. So once we have your assay ready to go, we take a sample of your blood. The blood can either be collected at your doctor's office, or we have a mobile phlebotomy program, and we'll send a mobile phlebotomist right to your house or your office, and there's no additional charge for this service whatsoever. We just want to make the process easy on you. And what we do is we use that assay that we created for you, and then we compare it to your blood, and we're checking to see if any of those little cancer cells are present in it. And we are extremely sensitive and extremely specific. We are very good at doing this. So this is an example of a report here. This patient had Signatera run even before they went on any treatment at all. So you can see that they're positive and their levels are quite high. During treatment, it drops. And in this patient, treatment was successful and it went to 0, and the patient was negative, which is what we want to see. And I have a larger report right here. So if you ever see your Signatera reports or want to request copies from your doctor, top left, it'll say if you are positive or negative. If you are positive, we will give you an actual number in mean tumor molecules per milliliter. And the reason for this is if you are positive, we want to track if you're going up or down, and you can't just have a positive or negative for that. You need to have a specific number that we can track. So this patient was in a survivorship program. They were negative for multiple time points. And it looks like they were doing testing every 3 to 4 months, which is generally appropriate in a survivorship setting. And then all of a sudden they got a positive. So this alerts the doctor, they probably want to run a scan to see if, even patient might not be technically ready for the next scan yet, but if the patient's positive, the doctor might say, we should run a scan on this patient right now, or increase the frequency of scans. Because if there's a positive, the cancer's back. It's just a matter of time before it's going to show up on the scans or not. And this can allow you to start prepping for a treatment program as well. So we are validated across multiple tumor types. We don't have a paper specifically addressing just sarcoma patients yet. We've been published in colon, breast, lung, bladder. We have over 20 different publications. But the whole gist of it is we work across all cancer types. And we are working on additional sarcoma research right now and hope to get that published soon. So these green lines are patients who are circulating tumor DNA negative. And what we're looking at is their relapse-free survival rates. So the patients who are negative have very high relapse-free survival rates across all these tumor types. The patients that have positive results, it does go down. So across all tumor types, our predictive relapse rate is 98%.
So that 98%, what exactly that is it's the ability of the test to accurately detect a relapse if one were to occur. So essentially, if you were ctDNA positive and you did not go on to have any type of therapeutic, help, the likeliness of that positive actually turning into a relapse is about 98%.
Exactly. And this right here is from our colon cancer data, just because I don't have any specific colon cancer data to show you. And just like Liz said, without additional treatment and getting a positive, this specific case was 97% for these colon cancer patients. But on the flip side of that, if you get negative testing with Signatera for 3 years, your risk of recurrence went down to 3%. And that's just such a huge, huge difference for these patients. Again, this was colon cancer. We're hoping to get sarcoma published soon. But to know that your relapse rate goes down to 3% over serial testing. I do have to say this means testing more than once. The real value in Signatera becomes to monitor these patients over time to see either if they stay negative so you can catch that positive early, or if they are positive, doing testing every, anywhere from 4 to 6 weeks if they're under treatment to see exactly what's happening with their circulating tumor DNA levels.
Yeah, it's almost like a molecular scan, because it's a real-time scan for your patient that's looking at their DNA. So instead of going through the invasive situations of a scan, this is just a blood test, which is like the molecular scan.
Yes. And again, we only run your pathology tissue, your biopsy once. After that, all we need is a blood sample from you. And we can schedule that either really easily through your clinic or through a mobile phlebotomist. But I do need to say, you need to have your physician order this testing. We are not direct to consumer. You need to have your physician involved in the choice of ordering this test and to go over the results with you as well. And we have full teams that can help support your doctor as they learn about the test as well and learn what the results mean and how to use it. So another use for patients besides a survivorship setting is patients who are undergoing immunotherapy treatment. We had this published earlier this year, and the goal was patients who are currently undergoing immunotherapy treatment, is it working? And if the immunotherapy is working, let's track those circulating tumor DNA levels to make sure that they are going down. So in our study, as early as week 6, an increase in circulating tumor DNA levels predicted a lack of response from Pembro, which was huge. You don't have to wait for the tumor to increase on the scans. That might take several months. The whole point is to catch this early. So if treatment's not working, you can change it up, you can switch it up.
Yeah, so if at week 6, 98% of patients never really achieve their objective response that they were looking for during their immunotherapy care. And immunotherapies are really expensive, and there's toxicity that's associated with them. So maybe that's not the right therapy for you and for your disease. And so as early as 6 weeks, you know whether or not you're going to respond. And maybe if you're not, you can add on another agent or you can change your agent. But if you are an exceptional responder, what a great way to know that you're one of those that are responding, that you can stay on it.
Yes. And looking further into the study, no patients who had an increase in both circulating tumor DNA levels and had an increase in tumor size on scans achieved any objective response during the study. So we are very good at detecting levels during immunotherapy. And we'll get into billing too, because I'm sure many of you are wondering how much this is going to cost. Just as a little tidbit before we get to that, if you have Medicare and you are on immunotherapy treatment, Medicare covers this completely for you.
Even if you're not on Medicare, if your commercial plan denies the test, we don't turn around and bill you. So it's at that point we write it off and it goes away. So it's an extremely billing friendly patient policy.
So this is, and I want to say in this immunotherapy study that we did, 2 of the patients did have sarcomas. This study looked at patients across many different cancer types. The whole point was to make sure that they were on immunotherapy. This one was specifically Pembro, but there were 2 patients in this study that had sarcomas. This is a very interesting graph. This was a patient who had head and neck cancer. And the green line on here showed the circulating tumor DNA levels for the patient when they went on immunotherapy. And the blue line was the size of their tumor looked at by CT scans. So you can see right away, Signatera could tell that immunotherapy was working, and the levels started dropping very fast, going down to 0. Scans, on the other hand, for this patient actually showed the tumor size increasing, which might cause the physician to think that immunotherapy is not working. This is a phenomenon called pseudoprogression that can happen. Scans did eventually show that the patient was responding to immunotherapy and the size of the tumor did shrink considerably, but it wasn't until month 4 that they correlated the scans and the circulating tumor DNA. So circulating tumor DNA just showed so much earlier that the patient was responding to treatment, and it was the correct choice for the patient to stay on this therapy. So another point made from this study that was done on immunotherapy patients was overall survival. Patients who cleared their circulating tumor DNA at any point on treatment, they got a negative result. They had a 100% overall survival rate.
Yes, so this is great for patients that have been on immunotherapy for a couple years and they're saying, hey, how much longer? I would really like to take a break. I just would like quality of life, maybe back for a little bit. If you're an exceptional responder, your likeliness of achieving that overall survival was 100%. And you know, along with talking with your provider, that the data shows you that it might be safe for you to take a drug holiday.
So again, great thing to discuss with your provider for your specific situation. The green line on here showed patients who did not quite clear their circulating tumor DNA, but it did go below the baseline taken before treatment was started. And unfortunately, the patients who didn't clear their circulating tumor DNA above baseline at all had the lowest survival rate. So again, it's about giving a real-time snapshot of, what's happening in your body at a molecular level. It's not looking a couple months or years back at your biopsy. It's what's happening right now on your journey.
Yeah, and we'll take biopsies back at least like 10 years. So if you had surgery 10 years ago, I've even seen them go back further than that. We can go back 10 years to retrieve your tissue. Except in those situations, like you've only had one primary, right? If you've had a second primary, then that's a different situation. But if you've had sarcoma the whole time and you've had surgery way long ago, that's totally fine. We will design it to your cancer, even if it's extremely rare. And all that matters is that that blood is telling the story and we're able to pick up any tumor cells in the blood.
Exactly. And so that was our Signatera product. We also have a product called Altera. It's for therapy selection. Again, this would be similar to, Foundation Medicine 1 test, Caris testing, Tempus solid tumor testing. We had a lot of clinicians ask us to start doing this testing for them. The reason is both therapy selection through looking at your tissue and Signatera, both tests need a piece of your tissue. And what happens is if you order them from 2 different labs, your tissue is getting shipped across the country to different places. And there can be delays because for both testing, you need a copy of that tissue at the lab. So Altera and Signatera can be ordered together or they can be ordered completely separately, but allows us to conserve tissue. Those of you who have sarcomas where there's not a whole lot of tissue left, we only take tissue off your pathology block once, and we can get both testing results from it versus having to ship it to one lab for one company. They take a piece of it and ship it to us, and we take a piece. So it conserves tissue and it conserves time as well for you.
Yeah, and one of the other things is just to put into perspective. So whole exome sequencing, what exactly does that mean compared to maybe some of the other things you've had? So Foundation Medicine is right around 500 or 600 genes. Which is, it's great, right? It can get the job done, but when you're dealing with a rare cancer, you want to turn over every single stone you possibly can. And so we're looking at 20,000 genes. We're actually looking at your whole exome of your DNA makeup. So regardless of where a mutation pops up, instead of kind of pinpointing it or 500 or 600 genes and hoping it pops up on there, we're turning over everything to make sure we exhaust everything.
Yeah, so we'll let you know if any targeted therapies are found, and we'll also let you know if you qualify for any clinical trials based on your sequencing results. So this is a little bit about the process of how our test works. Your doctor or their team would fill out a requisition form. We would receive that test order form. We would contact the pathology lab and start ordering the tissues that they send it over to us. And then each patient will get a welcome call from Natera, and they will go over the process with you, expected number of blood draws. They will offer you mobile phlebotomy, or they'll ask if you would like to, just have a kit shipped to you and have your doctor's office draw your blood. They'll go over turnaround time, and they will also try to qualify you for our compassionate care program as well, right off the bat. So we do all of this proactively. You're not sitting around waiting, how much is this going to cost me? What's the process going to be like? We reach out to you for it. And then billing, again, if you have Medicare and you're on immunotherapy treatment, full coverage. Commercial insurance, we don't have a lot of contracts right now. 99% of those claims will be denied, but that can actually work in your favor. If the claim is denied by your insurance company, we will not bill you for it at all. And then we have the compassionate care program as well. So we generally try to get you qualified for that right off the bat. And it's a very generous program too. I live in the San Francisco Bay Area. It's a very high income area, and you can make six figures and still qualify based on household size up here. So it's a very generous program that we have. And then again, the patient coordinators will reach out to you to schedule your blood draws, go over billing options. And generally the same patient care coordinator tries to reach out to you over your whole journey with us as well. So you get to know them a little bit, and they'll know your specific situation. And then every region has someone like myself keeping track of all the orders, making sure the process is going smoothly throughout it. And this is my contact information. Again, I'm the San Jose rep for Natera. But if anyone wants to email me with your city and your state, I can connect you with the clinical oncology specialist in your area. And they may already be working with your oncologist, or they may not be, but they can help the oncologist order the testing. But it goes a long way when the patient calls up the doctor, you say at your next appointment, I would like Signatera run. It really helps. But I can definitely get you connected with the clinical oncology specialist in your area, so they can help facilitate the ordering process for you. And when we take the slideshow down, I can put my information in the chat box too, so that way you can still reach out to me. And I can also send you, I can send you a digital copy of a patient brochure as well if you'd like to know more about the testing or have something to keep with you.
I saw one question in the chat. I think I answered one of them already about how far back we can go back with tissue. And then the other question is, what if a scan is positive and Natera is negative? So the likeliness of that happening is only 2%, because the negative predictive value of Signatera is 98%. So that false negative is only 2%, right? If we're looking at 100%. In fact, what we see happen more commonly than not is Natera is positive and the scan is negative. And the reason is because the scan, it doesn't pop up on the scan until like 0.5 millimeters. And so that's still really small, right? It has to get above that in order for the scan to actually start picking it up. Well, as with Natera, we don't need it to be a certain size. That's why this is picking it up before it catches on the scan. And so what you could do at that point is you can change the modality of scan. So you could maybe go to an MRI or a PET scan or something that's more sensitive instead of a CT scan. So you, as immediately as it pops up on that scan, you can do something about it. Sorry, I see lots of messages. Sharon, I don't know how you want to handle that. I'll let you do it.
Yeah, well, it's very impressive. I'm kind of blown away with the billing too, that this doesn't cost anything to the patients if your insurance doesn't pick it up. So it's a very generous program. I'd kind of like to hear from Dr. Ganjoo about the application, if she has any examples or stories of how this has helped in her clinical practice. Dr.
Yeah, sure. Hi, guys. I know some of you guys on the video. Good to see everyone. I have been testing patients for the past, I guess, a year and a half or 2 years. We've had some really interesting instances where the tumor cells, the Signatera test is positive, but the CT scan is negative. And in those patients, I was doing the surveillance, and I was doing the Signatera test with the CT scan every 3 months. And then if the CT scan was negative, great. But if the Signatera test showed that there were circulating tumor DNA, then I was worried that something is going to brew and the CT scan was going to become positive. So for those patients, I would get another Signatera test just to test. But for patients who are very high risk for recurrence, I would actually start them on treatment earlier. So now I'm actually alternating the Signatera test with the CT scan. So if I do a Signatera test now, 6 weeks later, I would do a CT scan, and then 6 weeks later, I would do a Signatera test. So at least every 6 weeks, I'm checking the patient's disease status. So if I do, at 6 weeks, if I do a Signatera test and it's all of a sudden positive, then at that point, I'm getting an earlier CT scan. If the Signatera test is negative, then I would wait for another CT scan 6 weeks later. There are a couple of instances, the high-risk patients that had positive Signatera all of a sudden, but the CT scan is negative. I know there's tumor there in the blood, and it's trying to circulate and go and get a home somewhere in the lungs or the liver. I would start them on treatment, and then I would follow the Signatera test, and I would definitely see that it's going down to 0. So I've got several instances like that. Couple of other patients that had surgery, and that's a really important question for Liz and Sam, is, I would do a blood test, Signatera test prior to surgery, and there was a level, right? And then after surgery, I checked one patient, the day after surgery, there was still positive Signatera. And the question to Sam and Liz, and a lot of the patients ask this, is when should we do the Signatera test after surgery to make sure that the surgery took all the tumor out? Is it correct to do it a day after, or do we need to wait 6 weeks to do the Signatera test and make sure that the surgery cleared all the tumors? So Liz and Sam, I'll let you guys talk about that.
Yeah, great question. So generally we recommend after surgery that the patient wait 2 weeks prior to having their blood drawn. And the reason that we do that is because there's a lot of inflammation still in the cells from surgery. There's a lot of mad cells. I mean, your body just went through trauma. And so essentially we're trying to have everything kind of die down in order for us to get a true cut of what's going on in the patient's blood. And so we do request that if you have had surgery, you wait 2 weeks after that, and then you can have your blood drawn. One of the questions was around surgery and the likeliness of this test being positive prior to surgery. So technically 100% of those tests should be positive if you're having your drug. That's called a baseline test, right? Before surgery, before therapy, anything like that. So if you haven't had surgery yet, 100% of those tests should be positive because you have active disease in your body. Mm-hmm. Did that help, Dr. Ganjoo?
Yes, that definitely helps. So 2 weeks after surgery is what we've been now doing since I did one patient the day after surgery and it was positive. And then the follow-up test a few weeks later was totally negative. So that really tells us that and that was a Leiomyosarcoma patient. And then the other thing that I really like is the Natera test, the tumor tissue test, because I know that the Natera folks, you guys, need that tissue to look for the DNA that is the type for that type of tumor, and then to look in the blood for that DNA. So since you're getting the tissue anyway, I've been doing the Natera testing now more frequently now over the past year. And it gives me so much information on targeted therapy. There's several of my patients with uterine leiomyosarcomas, and you guys all know that they have BRCA1 or BRCA2 mutation in their tumor. And that totally helps us with targeted therapy with Lynparza, all those PARP inhibitors. So now if I order the Signatera blood test, I always order the Altera because it gives me a lot of information as far as, and just to tell you, I don't have any conflict of interest with Natera. So I'm just saying this based on my experience with the lab test. And it really does help figure out if there is any targeted therapies we can use, if there's immunotherapy that I can use. I've used the Altera tissue testing for multiple patients with uterine leiomyosarcoma and other leiomyosarcomas that have given me a lot of good options on a targeted therapy. But I've been doing the Signatera test in several instances. Surveillance is really important. That's what I was describing, that every 6 weeks patients will get analyzed either with the Signatera test or with a CT scan. The other times, so that's surveillance. That's patients that are not getting any treatment and they're supposed to be NAD without any evidence of disease. The other time that I use it is obviously during treatment to see whether or not the circulating tumor DNA is coming down. I had an instance where I was giving immunotherapy to a patient with sarcoma, and the CT scan showed a little bit of a fluffiness. So I thought, okay, it's probably pseudoprogression. But and then the circulating tumor DNA was starting to come down, but as I rechecked it again, it shot up like totally off the charts. And at that point, it was after 3 doses of immunotherapy, and I knew this was not working. So I didn't want to put the patient through, the immunotherapy that's not working. And with the Altera tissue test, I was able to find targeted therapy, which was mTOR inhibitors. So now the patient is on that, and I'm following the Signatera test to see if he's responding to that. But interestingly, that very same patient had a very odd mutation that I've never seen in sarcomas. And there is a new drug that was just approved for other cancers that I was able to I'm trying to get authorization for that patient, because it was really, I've never seen that type of fusion for this, for malignant peripheral nerve sheath tumors. So it's very important for these rare diseases, because we used to say, oh, this is leiomyosarcoma, so I'm going to give this chemotherapy, which was ridiculous, but we didn't have any other guidance from anything. But now, I mean, I can see these leiomyosarcomas are so different. The kidney ones are different. The uterine ones are different. I mean, they're just so different that treating them all the same is ridiculous. So we're still learning, though. We're going to be Liz and Sam and I and one of our residents were working on the paper for trying to figure out how to publish our results. We have about 100 some patients. So we'll get more on that for you guys later. But we've had so many uterine leiomyosarcomas that have tested for this. So I will be able to give you more information after we analyze our data.
Well, I bet you're going to get a bunch more now.
Yeah, I know. I know. Some of my own patients haven't, we used to do other tests with other companies before Natera allowed us to use their test. And some of those patients, I'm repeating their test through Natera, and I'm finding newer mutations. I mean, just really, that's very odd. I'm finding newer mutations that we didn't see before. So I know some of my patients are going to call me and say, I want it now. But so I'm going through my list to try to order it for everybody. So.
Oh, that's wonderful. That's wonderful. Someone asked in the chat, why aren't all doctors using this?
Yeah.
Well, because I was talking to Sharon, you just prior to starting, is that a lot of the, I would say 90% of the sarcoma physicians are not using Natera yet, just because there's no data. As soon as we publish our data, at least they will kind of say, oh, it really does work in sarcoma too. And they may start ordering it. But I have one patient that has angiosarcoma of the breast that I did Signatera for and Altera, and her level was negative after all the chemotherapy that we did, all the surgery. And then it all of a sudden started going up, even though the scans were negative. I started treatment for that patient, which was really interesting because it was a targeted therapy and it's just a pill. and the levels went right to zero. So it really helps those very aggressive tumors, which are the blood cell vessel tumors. As soon as they start showing up, you knock them down. And I was thinking for this patient, do 6 months of this pill, and then hopefully we'll kill all the cancer cells instead of waiting for the tumor to show up. And the person went to another sarcoma specialist, and they said, well, we haven't been really using any kind of blood thing, but we're thinking about using Signatera for that. So everybody's now thinking about it. It's such a new tool for us, just because the initial studies were in other cancers. So I'm sure pretty soon everybody will start using it.
So patients could tell their doctor about it, and their doctor could make a call or look into it?
Yes, so we have several ways that we can order it. Everything is now online, and Liz and Sam can correct me if I'm not correct, but patients can actually sign into their account, and they can see their results, right, Liz? Sam?
No, we don't have that yet, but it is coming shortly.
Good. Okay.
Soon, hopefully it will be there. But what we can do is we could always send results to patients as soon as those results post out. Natera can turn around and send those to the patient.
Yeah, and that's what I requested. I asked Sam before, because sometimes I get so busy and I don't get a chance to send it right away, like the same day as I get the results. But there's a portal that I sign in, and I have all of my patients there, and I can see all of their results. And it's a really user-friendly website, because I can copy it and I can send it as a patient message to the patient. And then I explain it. But sometimes I send it to patients and then they ask me questions. So what does this mean? So then I explain. But it's really, it's a really good tool. I think one of our patients here has been in remission for a long time. And, we don't want to do too many CT scans, Sharon, like for 20 years, like with LMS, because you can have a late recurrence. I've been starting to do this more so, the Signatera test more, and it kind of gives us reassurance that nothing is showing up, instead of for patients having CT scan every 6 months for 20 years. So
that's a relief. I'm in that category. I've been NAD for 16 years, but I still get annual scans. So I was telling everybody I glow in the dark,
And we only need
take a blood test.
And we only need your tissue once, right? So, we run the tissue once. That does take 3 weeks. After that, we only need a blood sample from you. And once we have the blood at Natera and it's sent to us, about 1 week turnaround time to get those results to your doctor.
So the first result usually takes about 3 to 4 weeks, Sam.
Yeah.
And then subsequent to that, it's really easy. I mean, after a week we get the results. And one of the chat patients is asking if they have no disease, then how often should they get it? So if they're doing surveillance, I usually do it every 6 months. If they've been out for a long time. But if they're just fresh after surgery, I do it every 3 months. And I think somebody else asked a question. This one is really tough. In terms of virtual visits for out-of-state patients, I think they only allow us to do video visits for patients who are in Nevada, and California, and maybe in states that do not have a sarcoma specialist. So, we have this little table. So that was one of the questions, if we do that. So the other question is, if you get another tumor elsewhere, say that one in the uterus and was NAD, but then got a tumor in the breast, would that second tumor need to be profiled separately? It depends. If the second tumor is also the same tumor as it was initially, then I usually don't send it, profile it, if we have the original tumor. I don't know if I answered your question. Sorry, Sharon, I'm taking over your role.
I love it. Yemi asked very early on, how long ago is it okay to use a tumor sample? So I go back 19 years. Can you use a sample from 19 years ago?
As long as they have it in paraffin, right, Liz and Sam, they can use it. Wow. As long as the pathologist has kept it, yes. They keep it in these little blocks, And I've been impressed as how Natera can use the tiniest amount of tumor and be able to, give us results from the tiniest. But yeah, as long as the pathologist has it and it's in good condition, they can use it. Right, Sam?
Yes, condition does degrade over time. That being said, I've personally seen samples that were 12, 13 years old that we were able to run. If it's older than that, we'll definitely try it. And if it doesn't work and we can't sequence it, you're not going to be charged. Your insurance isn't going to be charged. It's at least worth a shot.
Yeah, and the other one, Heidi is asking if she's been, has no evidence of disease for 9 years. Is it valuable to do a Natera test instead of annual CT? For that particular, for you, Heidi, I would probably do the Natera test at 6 months, and then you get a CT at 6 months. So you alternate. So at least you have some point of, reference. So you're not waiting a whole year and then all of a sudden you have a tumor there, So at 6 months you want to do the Natera test, and then 6 months later you do your CT. Every 6 months you're checking yourself out. Do hospitals know if Natera has been profiling for, do you know if for chordoma? I don't know. We haven't profiled a chordoma yet, but I will ask Sam about that.
I'd have to double check that one. I'm not quite sure off the top of my head.
Yeah, I haven't sequenced the chordoma yet. And then does Natera request the tissue sample, or how do you get? Yeah. Okay. You answered, Sam.
We will do all the work getting the pathology tissue from the pathology lab. There's a whole process. We request it, and they send it over to us. And then either your doctor's office will draw the blood and send it in to us, or when we give you that patient phone call, we will let you know that we need to set you up for mobile phlebotomy, and we can send the phlebotomist directly to your house or your work or wherever you like.
And Laura is asking, my primary uterine tumor was in 2004, but I had a recurrence in 2020. Would you want the sample? I would definitely get the sample from 2020. These tumors mutate over time. So if you have a sample at 2020, that's the tumor you want to be sequenced, not the old one. And then Gigi is asking, I have to get scanned every 3 months for 2 years. Does this test eliminate some scans, or would I? So if you're fresh out from being treated, you cannot replace your scans in the first 2-3 years, just because those are still standard of care. And you can add that Natera test somewhere, in the middle of your scans, but I would not change the scan scheduling for now, since you're very close to your initial diagnosis.
That's good to know. Yes.
I see a question asking if pathology offices keep the paraffin blocks indefinitely, and the answer is no. It actually is state dependent. My first job out of college was working in a pathology lab, so I used to work on the paraffin blocks myself. And each state has a different length of time they require the pathology labs to keep the tissue for. That being said, we generally try to sequence your most recent tissue first. If for some reason that one doesn't work, we can proceed to older biopsies or resections that were done.
And Sam, I had a problem with New York. Samples not coming out. So can you explain that? Some patients go to MSK for their surgeries, but explain that for us, why we cannot get pathology samples from New York.
New York likes to be very special, and they have a completely separate accrediting process than all other states. They do 100% their own thing. Right now, I believe we can do testing on a paraffin block in New York, but it has to be ordered by a New York physician. Dr. Ganjoo, they won't let us request it if you are doing testing on the patient. It's something that this affects many labs across the whole industry. This is not a rule they have for Natera. New York is just very hard to deal with in general. They say it's to protect the patients, but it really stops testing when the lab or the provider is in a different state, because people move, things happen. We can work with New York, but it's generally a lot easier if a physician from New York is the one ordering the testing.
Yeah, so we had several patients that went to MSK Cancer Center to get their surgery, but then when I ordered the Natera, we couldn't get the sample. So, and then the New York physicians are not yet ordering Natera, the sarcoma specialist, so I couldn't get the sample out of there. So that was, I was kind of lucky because the patient lived in Ohio and she had some sort of surgery there as well, so we were able to get that. So we bypassed them. Yemi is asking if you had said that the Natera surveillance sometimes will make you start or alter treatment even without a scan. Yeah, so with the Signatera test, the blood test, I alter the treatment if the initial treatment is not working. That means the level is going up. That's the only reason I would change the treatment. And if it's positive and you're not on treatment, then I would also start treatment to make sure that it doesn't spread.
Great. Any more questions, folks? We're running out of questions in the chat box. And you can just unmute yourself and ask your question too. No?
I have a question.
Okay.
I'm wondering if you would only order, so if you're NED, you would only order the Signatera or the, I'm kind of getting them confused.
Yeah, so if you're NED, Dundee, I would only order the Signatera right now because if the Signatera is negative, I'm not going to start you on treatment. But if it shows positive, then I'm going to do the Altera test, the tumor test, to see what treatment I should give you. Okay. But right now, I would just do the Signatera, see if there's anything in there. And it's because all of these tests are actually improving over time, right? So if I do the Altera test now when I don't really want to treat, then if it does come back in 2 or 3 years, then I want to make sure that the most recent Altera testing is done. So because all of these companies improve over time because the science improves, right? So then I would do it at that time.
Your tumor is changing over time as well. So with Altera, we always want the most recent biopsy. A biopsy for 3-4 years ago is not nearly as helpful as one from this year or last year, because the whole point is to find a targeted therapy that can help the composition of your tumor right now. And from 3 or 4 years ago, it has likely changed.
I didn't hear how much the Altera test is.
Same thing. We bill your insurance, and if they deny the claim, it's $0.
That's amazing.
If insurance, we do have insurance coverage for Altera. If insurance does cover the test, we legally have to bill for copays and deductibles. That being said, our patient care coordinators, when they call you, we try to enroll everyone in our compassionate care program. That way, if your Altera is approved and you have some type of copay and deductible, we don't legally have to bill you for it.
And what about, say if you were going to bill someone, Sam, how much would you bill? Because I heard $295. I mean, compared to other companies, they're like $2,000, $3,000. Is that true? Because say if a company says, I'm going to pay 50%, I just want to make sure patients are not liable for half of the $2,000, you know?
We do bill insurance a couple thousand. So that's why it can depend on the patient's copays or deductibles. Especially if a patient has a high deductible or high copay, we want to get them on our compassionate care program. That being said, I've been here almost a year. I work highly with Stanford. I have a lot of testing done in my territory. And at the end of the day, I've never had a patient completely upset with me about a bill. You get a bill, and our patient care coordinators can't get you qualified for some reason, give me a call. There's other things we can use to get you qualified. Mortgage amounts, medical debt, student loan debt. We have so many ways to get you covered for this testing. I don't want anyone to not get the testing because they're worried about a bill. Patient care coordinators will help you with that. At the end of the day, if something goes wrong or you got a bill you shouldn't have, or you get a bill at all, just call me and I will work with you.
Yeah, one of the other nice things is that, so say if at the beginning of the year your deductibles and everything reset, and maybe they're really high, maybe they're like $5,000, and that's a lot of money, you know, for anybody to come out of pocket with. If you'd rather not go through insurance and just pay the cash price of the test, The cash price of the test is $395, and then your insurance never gets billed. So those deductibles or copays that you might have to pay in the very beginning, you can use them towards something else that you'd like to use them for.
Wow, great. So we've got a couple people in the chat box want to know how to work with their doctor to get this if they're skeptical.
So
Samantha,
definitely
do a lot of calls back and forth, or what do you do?
Yeah, so usually when a patient requests testing specifically, many doctors will order the test, even if it's not standard in their practice. A lot of them put a lot of heavy weight to what the patient's asking for. That being said, let us know as well. Email me. I can link you up with your local clinical oncology specialist, and you can tell your doctor you want this test, and then my counterparts from across the country can go into the office, give them the requisition, show them how to order it, and let them know that the patient is requesting it. And we are a very new test. We've been around for a couple of years. Some doctors are just slower to adapt to new technologies and testing than others are. But at the end of the day, this is the conversation between you and your doctor to get ordered. I saw a question in the chat box. You cannot order this testing yourself. You must go through a physician.
Okay, good to know.
The other question they have is Kaiser that we've had issues with. Kaiser will not order it. So, if you see someone else other than Kaiser as a second, as a second opinion, they can order it for you. But for Kaiser, I've had Dr. Mingui Pan. He's excellent, sarcoma doctor over there, and he runs the program there, and he will order it. Because I've asked them a couple of times about a couple of patients, and he's ordered it. You just have to talk to the sarcoma specialist, because I know some of you at Kaiser get treated with regular oncologists, but Dr. Mingui Pan is always involved in if your case is taken to the tumor board, Kaiser Sarcoma Tumor Board. But ask your doctor, and they will order it, because that's what I've seen with Kaiser recently. So that's good.
That's excellent. That's good news for us. Yeah. Any other questions?
They were asking about a sarcoma specialist in Oregon. Yes. Let's see. Oregon Health Sciences University. They have several sarcoma specialists there. I'm blanking on his name, Christopher. So, but there are sarcoma specialists that are at the Oregon Health Sciences University. There's 2 of them there. So they can see you and order there. And then
and Dr. Ryan, Chris Ryan. Is
Chris Ryan, yes. Gosh, I was like blanking. Chris Ryan, yes.
I had a question. I put it in the chat, but I guess you didn't get to it. I spoke to Dr. Bowie this last week, and I asked him about it because I knew this presentation was coming. And he said he felt it was too experimental, and that because I have an NED diagnosis right now, it wouldn't change any treatment. But
yes, Dr. Bowie and I need to get together, and we're both writing up our experience. And before Natera became, we were using Natera, we were using a lot of foundation medicine. So Dr. Bowie I just need to, we need to establish a practice for us. So Dr. Bowie and I were supposed to talk after this meeting just so that we can get input, from you guys, and talk to Sam and Liz, but we will be ordering those now. Because Dr. Bowie and I work together, yeah.
So I should then.
Yes. Just say that, I will talk to him today as well, but we haven't established a definite program, like an algorithm yet for sarcoma patients at Stanford, but we are doing that pretty soon after we look at our data from Natera. So that is coming.
Yeah, and Natera's, it has been fast-tracked by the FDA as a breakthrough device. So it's no longer in those experimental stages. Providers are using it for, therapeutic implications. And now one of the things that Dr. Bowie might be waiting for is, the outcomes data, the predictive data in this test. And we have that data now, whereas we didn't have it before. So thank you, Dr. Ganjoo, for bringing that stuff up with Dr. Bowie.
Yes.
Okay, we've got 2 hands up. Lisa, Were you waiting for a question? Hi, Lisa.
Yeah, hi everybody. Hey, I just want to do a shout out to Natera. Jessica Phillips works with you guys. She directed me to you guys, and I have had the privilege of speaking to somebody. They have actually scheduled my blood work this coming week. My specimen is in the mail. So I'm very happy about all of that. So I just wanted to do a shout out. I don't have a question. I just want to do a shout out. This is great.
It's
Wonderful.
good.
Thank
Got
you,
an
Lisa.
endorsement. How about JR? You want to ask a question? You're muted though. Your hand is up.
Yeah. Okay. So, hello all. Just really quick, this question is directed to Dr. Kristen. Are you familiar with Dr. Kramner? He works at the Seattle Cancer Care Alliance. I absolutely adore my oncologist.
Yes, he's excellent. Dr. Kramner is excellent. He should, once we publish our data, I think most of the sarcoma specialists will then start ordering. Okay. And we're working very hard to get the data out there because there's nothing written. Sam, you can correct me if I'm wrong. There's no publications for sarcoma and Signatera. So we're doing that.
Not specifically. In our immunotherapy paper, referred to as the Brotman paper, there were 2 sarcoma patients included in that study, but no studies just on sarcoma yet.
Yeah, so I think once we give them a little bit of data, now that we have 150 patients tested already, then they will start ordering it.
Okay, very good.
I know MD Anderson is not using it yet.
Okay, very good. That's what I need to know before I'm going to talk with him, not this week, but next. So knowing that he's familiar with you and also Natera, Samantha. So as long as he's familiar with that, I don't have to go too in depth with the information that I'm going to bring with him.
Yes.
Yeah. Okay. Fantastic. Thank you.
And Samantha, did you say you have brochures you can give?
Yes.
Out?
Yeah. So Sharon, why don't I send you a copy of our digital patient brochure, and then you can send it out to everyone who logged into the call today.
Yeah, I'd be happy to. So that's also something you could give your doctor is the brochure. Okay. Sean, you have your hand up?
Actually, it's I'm his wife, Claudia. And I just had a question. I'm in Montana, and there's no sarcoma specialist here. So I end up going to Dr. Zarzur at MD Anderson. And if I can get her to, and she's very open, we kind of talked to her about it, so she's open to learning about it more. If I can get her or my local oncologist to order the test, who is going to be kind of monitoring and doing that surveillance that Dr. Ganjoo was talking about for someone like me? Who would be doing that? Would it be, I mean, Dr. Zarzur is not, she's going to order it, but who would be doing that surveillance?
So it would probably be the MD Anderson folks that you're seeing, but as soon as it's positive, then the doctor that's ordering it can let the MD Anderson sarcoma specialist know that it's turning positive, that you need a new CT scan. But Sam maybe can help connect you with the person that's over there, right, Sam?
Yes, the local rep, and we can also like say MD Anderson's ordering the testing for you. We can also send a copy of all your reports to your local oncologist too. That way, every time a report comes out, it would automatically go to both of your physicians.
Very good. Gigi, did you have your hand up?
Yes, thank you. So I've also seen at MD Anderson, would I ask for this? So since I'm currently NED, I asked for Signatera, not Altera. Is that correct?
Mm-hmm. That's correct.
Okay. And then once the 2-year mark is passed, will this test ever replace the CT scans?
It will be alternating, right? So if your oncologist says, well, I'm going to do every 6-month CT scan, And then at the 3-month mark, you can do a Signatera test. So you're not waiting a whole 6 months without a scan. At least you have some monitoring that you're doing at month 3 with your blood test, and then month 6, you get your CT scan. Because a lot of the insurance companies have seen that after 2 years, they're not covering the CT scan at every 3 months, and you may not really need it. But that Signatera test at month 3 is going to really help you. If it does come back, then we can say, let's do a CT before waiting another 3 months for the tumor to grow to a bigger size.
And I know several of you have mentioned being seen at MD Anderson, and while the sarcoma doctors are not currently ordering this testing consistently, MD Anderson as a whole is. Oncologists for other cancer types are. So our rep is still very familiar with MD Anderson and with the pathology lab there as well.
Okay, we have time for maybe 1 or 2 more questions. Anybody?
I think Andrea has a question.
Andrea.
With MD Anderson 4 years ago, I had a reoccurrence, and now I'm being seen at Houston Methodist. Are they active in this as well, or is it something that I need to bring up to my oncologist at Houston Methodist?
No, Andrea, you can talk to your oncologist that's currently taking care of you, and you can email Sam, and she can tell you who the local rep is, and that local rep will reach out to your oncologist, local oncologist.
Okay. All right. Thank you. I appreciate it.
No problem.
Okay,
and there's the last question. Sherry is asking you a question. Has there ever been a false positive on the Signatera test? Altera test or Signatera test, Sam?
So you're saying if Signatera is positive, I think it's like I think we're 98% accurate on the positives. And I say over time, we're probably even going a little bit higher than that in our accuracy. No test is ever 100% accurate. We get as close to it as we can, but no company should be telling you that a test is 100% accurate. That's just not good science. But our test is just getting better over time.
And Dana has a question saying you had first advised to order both Altera and Signatera to save resources, but now you say only order Signatera. I say to order Altera and Signatera if you have active disease, if you're actively, are getting treatment, or if they're planning to get treatment. But if you're on surveillance, we can do the Altera if the Signatera turns positive, or if the CT scan turns positive and you're trying to get treatment, then you do the Altera. And that is really simple because the Natera company who does the Signatera will have your tumor anyway. So, right, Sam? And they can just run the Altera quickly, so they don't have to call out and get the tumor sample. It's already there. Right, Sam?
If we still have it. Altera testing takes a little bit more tissue than just Signatera. And so I believe, I just got back from maternity leave a week ago, so I'm trying to keep track of all the changes that have been happening. I know for a while, if we were just running Signatera, we would use the lesser amount of tissue because we didn't want to use up more for something we may or may not use later. But I think now they're trying to do it to where we just run it once and you could get Signatera and Altera both on it, but I would have to double check that.
Yeah, I mean, if you are like 2 years out from your surgery and initial diagnosis, it makes sense to do both. But if you're, 5 or like Sharon, 16 years out, it doesn't make sense to do the Altera. Signatera would be just good. But if you're just like a year or 2 out from surgery, there's a higher likelihood for the tumor to come back. It'll make sense to do both testing.
Okay, very good. Well, it's a little past 2 o'clock. I want to thank our guests. Can you all give them a virtual clap? Yay! Thank you so much. And this will be available. So, Dr. Ganjoo, you can refer new patients to look at it on our website if they need some explanation.
Great. Oh, that would be great. Thank you.
Yeah. And Sam,
please don't hesitate to reach out to me directly. I put my email in the chat box, and Sharon has it as well. You can also call the main Natera phone number. I can give that to Sharon too, or just by Googling us, and we can have you talk to a patient coordinator right then and there too. And they can also send your information to the specific rep who covers your region.
Well, this was very exciting, and it gives a lot of us a lot of hope in our hearts. And, you know, we're just so thankful that you were able to share this with us today. So thank you all. Have a great Labor Day weekend.